Hello, my name is Irie Selkirk. We are here for the Psychedelics Anti-Addiction Drug Panel. Dr. Ben Sessa is a child and adolescent psychiatrist consultant trained at UCL Medical School, graduating in 1997. And he is interested in the development trajectory from childhood maltreatment to adult mental health disorders. Dr. Sessa is an approved MDMA and psilocybin psychotherapist, currently a senior research fellow at Bristol and Imperial College London universities. It is there that he is conducting UK's first clinical study with MDMA-assisted therapy for the treatment of PTSD and alcohol dependence syndrome, and I understand that that's actually coming to fruition soon, that study report. And he is also the lead therapist on a Bristol-based study investigating the role for psilocybin therapy for depression.
I'm on there now, and it should work, okay?
Oh, there you go. Okay, he is currently working with industry figures to set up a network of UK-based psychedelic therapy clinics. And in the last 10 years, he has worked on several UK-based human pharmacology trials as a study doctor or as a healthy subject administering and receiving test dose of LSD, DMT, psilocybin, MDMA, and ketamine. That's quite a broad range there. And he is widely published in the popular media as well. And you can find him on his website at drsessa.com. And while I'm on the roll here, I imagine everyone is together, but now I do have introductions. So Dr. Camlet, I'll just go ahead with yours if you don't mind. Dr. Camlet is a medical physician practicing in the United States for over 30 years. Dr. Camlet is an expert in the fields of internal medicine, cardiology, emergency medicine, and forensics. He is board certified in addiction medicine and a diplomate of the American Board of Addiction Medicine, and holds many other certifications in other fields of expertise. He has no idea what he's talking about at all, clearly. This is incredibly impressive. He has served as a principal investigator in over 25 pharmaceutical clinical trials. He was an adjunct professor of medicine at several medical universities. He's been researching the medical use of psychedelics for over 35 years and is recognized worldwide, as well as an expert on ibogaine, which has been featured in the National Geographic Breakthrough Series. He's also a keynote speaker on drug policy and a pioneer in the field, and states this as one of his main reasons for becoming a physician scientist teacher was to see a safe, ethical, and science-based model of psychedelics in mainstream media. And I say kudos, thank you, excellent. I'm glad you made that choice. Welcome. Sorry for the technical difficulties, everyone. And for the time being, we are going to go with our original plan, which was why don't each of you just take a few minutes to briefly discuss your work and give a spiel of what you're doing, and then we'll follow up with some questions from the group. Hopefully they're going to make it really easy on us and give us some, because it's been a fun start, and I've got some as well. So Dr. Camlet, would you like to start?
Sure, thank you. Thank you all for being here today. And I'd briefly like to tell you, my main reason for becoming a physician was to one day study psychedelics as medicine. After having my first psychedelic experience, I said, oh, these medicines are of great value. And if everybody would have the same experience that I had, the whole world would be in order. I've since learned otherwise. I practiced emergency medicine as a director of an ER for approximately a decade, when in 1997, my medical journey, once I got back to the United States, took me very far away from anything that had to do with psychedelics. Prior to this, I had spent a lot of time in the mountains with the huichols, the peyoteros. I was running around searching a drug called yahe in the Amazon, which is now known as ayahuasca. So I'm an old timer, and I came back here, and this is like Hoffman, Huxley, Stanislav Grof. Hoffman called his book LSD My Problem Child, and I think this is where we are today. Also, if you're interested in how I got here, MAPS published in their spring journal an article called "The Commercialization of Ibogaine," and it tells a little bit of my story, how I got into this. But in 1997, a PhD brought me a drug that she said, I can detox opiate addicts in 24 hours in what takes to do in a 90-day model in the US system. And I saw nothing short of a miracle happen. Now, watching yesterday's seminar, it disturbed me a little bit that we have to get these drugs legalized through a backdoor policy. So in other words, we have to say a drug fits a psychiatric diagnosis and is a cure or assist in that psychiatric diagnosis. Where I personally believe that psychedelics are a benefit to anybody that takes them. But yet I have to make up, like, ketamine is for refractory depression, and ibogaine is for opiate dependence. There's broad spectrums to these molecules. So the interesting thing about ibogaine, which is different than all other psychedelics, is that ibogaine is the only psychedelic substance on the planet which will greatly ameliorate opiate withdrawal in less than 24 hours. I have done thousands and thousands of treatments without an adverse event. So yes, ibogaine is not a drug that is as safe as LSD and other drugs, but there is a protocol that can be followed here in the United States, a simple protocol where this is done by expert physicians who are trained to do this, just like MDMA is not going to be done by just anybody. It'll be done by people trained to use this substance. Ibogaine, used in a safe, ethical model with a protocol, can be done with 100% safety. And in the face of a global opiate epidemic, how important is this drug? Now, the studies done in St. Kitts were over 16 years ago. The reason this information was not made public till 16 years later is, this is a problem. We are getting into the commercialization of psychedelics. And when for-profit companies, say this is a good idea, but yes, we still have to fit the US pharmaceutical model where no drug is a good drug unless you have to keep taking it, it's an uphill battle in the United States. Having done many pharmaceutical clinical trials for Big Pharma, the cost is exuberant. And if it doesn't make profit for Big Pharma, it's not going to happen. Another thing of great interest to me is that I've been using ketamine intravenously to treat refractory depression in my practice for approximately a year. A few of those patients were addicted to Suboxone from dosages of 8 milligrams down. And I started a protocol using ketamine to detox patients off Suboxone. And I've only done this 3 times, but all 3 patients now have weeks to months clean with little or no withdrawal. So I have a new protocol, which I'd be glad to share, with some people. I'm not going to put it out there on the open now, or what will happen is what happened with ibogaine. I went around telling everybody how to do ibogaine safely, and I did ibogaine, I had the experience, and I want to work in this drug. So they started giving ibogaine to people, but they had no medical expertise. They weren't able to handle emergencies that may arise from the use of this drug, and patients died. So I'm a great advocate for safety and ethics in ibogaine. I also believe that any speaker lecturing here on SciTech should state if they have any affiliations with any companies. Every time I speak at a conference or regular medical conference, it's mandated that I state if I'm working for any drug companies or if I'm on the board of directors of Atai Life Sciences or something like that. So I'm here to say I have zero financial interest in any of this. I'm giving away all the knowledge I can in the hope that these drugs, in my lifetime, I will see ibogaine available in the United States as a safe, effective treatment for everybody that suffers from opiate addiction.
Well,
now,
and that's spoken just like a true psychonaut. I have to pop in and just say quickly, thank you very much for saying that. It's interesting, that was a common thread that comes up, is the integrity of this and ensuring that we honor that, especially as we commoditize and have all of these massive financial interests hop on board with what we're doing. I don't want to cut you off there. I do want to hear more about that. I just want to make sure that we get an introduction from Ben and some of his work, and perhaps any thoughts on what Dr. Camlet has just mentioned, and then we can get into some of the questions here, because I find that fascinating that you found a new protocol. So
may I end this with 5 seconds?
Oh, absolutely.
I have something I call, for anybody giving entheogenic drugs to anybody, and I call it tips, okay? It's a tip. Right time, right intention, right place and people, and right substance, okay? So, don't treat somebody that you've just spoken to on the phone. Sit down with them. If these people have the slightest schizotypal personality disorder, these drugs may not be good for them. So do your due diligence. These drugs can be used in a safe, effective manner, but, these clinics where they speak to a patient on the phone and the patient flies in. I have a saying, real shamans don't advertise, don't have web pages and business cards, and also don't charge. So I'll let Dr. Sosa introduce himself. Thank you.
Hello. Hi, can you hear me?
Yes.
Yeah.
Yes, hi, my name's Ben Sessa. I'm a consultant child and adolescent psychiatrist from Bristol in the United Kingdom. Thank you for having me here. So I've been working in the field of psychedelic research about 15 years. I published a paper in the UK medical press in 2004 in the British Journal of Psychiatry, and that was the first paper on psychedelics since the 60s in the British medical press, and opened up a whole fascinating career for me. And since then I've been working out of Bristol University, Cardiff University and Imperial College London, where I've taken part in studies with LSD and psilocybin and DMT and ketamine and MDMA. And I've just finished doing the world's first addiction study with MDMA-assisted psychotherapy, which is a really interesting new direction for MDMA because, as you probably know, pretty much all the work on MDMA so far has been with post-traumatic stress disorder and the work of MAPS. So ours was the first non-MAPS study with MDMA-assisted psychotherapy in this new condition in treating alcoholism. And we have some really great results on that. Throughout my career, I've worked with children and adolescents. And for the last 8 years, I've been working more than young people. I've been working with adults in the field of addictions and forensic psychiatry. And I do a lot of court work and legal work. And so for me, it looks like a very disparate and disjointed job plan in many ways, with a little bit of children, adolescents, adults, addictions, trauma, PTSD, combat PTSD, forensics, offending behavior. But it all makes sense in my head because it's all held together by the concept of the developmental trajectory from childhood maltreatment and abuse into adult mental disorder and addictions. And I've been a psychiatrist for just 20 years, and in that time, it's very rare to meet patients who are wholly satisfied with their childhoods. I mean, there's what we call the big T trauma, the sexual abuse and the physical abuse, but there's an awful lot of emotional abuse and neglect. And I'm certainly not saying for a moment that anybody with an adult mental health disorder or an addiction has had a poor childhood. I am not saying that for a moment, but it is very highly represented in this group. So I always take a very developmental aspect with all of my clinical work. And one thing I always urge trainee psychiatrists when I'm meeting them is do a good 5 years of child and adolescent psychiatry. Because it makes you an excellent adult psychiatrist as well. I've never met an adult yet who isn't basically coming forth with the opinions they learned when they were 2 feet high. The concept of the attachment relationship as a blueprint for personality and psyche is so well established, and especially when it comes to trauma. If you damage a sapling, you get a wonky tree. And this is very, very clear, and it's a very strong effect size in psychiatry. And the thing that drives me really is that we have so much sentimentality and understanding for abused children, and we have so much empathy. But then what happens in the general public is they forget what happens when these kids grow up. So these little 4, 5, 6-year-olds who we have all this empathy for, when they're 12, 13, 14, and they're wearing their hoodies and they're nicking your motorbike and they're begging in the street, and then they become addicted to heroin and then alcohol and then cocaine, and suddenly we've lost our sympathy and understanding, we've lost our empathy, and we just consider these people public enemies, and it's a lifestyle choice, and they could stop using these drugs if they wanted to. They just want to get high. It's outrageous really how we manage to have that empathy for children, but we forget that very clear developmental trajectory. And so all of this over the years has brought me to the door of psychedelics, and particularly MDMA. I think MDMA is a profoundly important molecule when it comes to assisting trauma-focused psychotherapy. It has this quite remarkable ability to uniquely and selectively turn off the fear response whilst leaving the other faculties intact. Of course, many drugs turn off fear response. Heroin is very good at turning off fear response. Alcohol is very good at turning off fear response. But those are very messy, dirty drugs, so you can't work on those drugs. MDMA is quite remarkable that it's literally just the fear that's turned off, and they can otherwise talk and remember and discuss and debate and reflect on past distant memories, but without fear. That is, in some ways, the kind of holy grail of trauma-focused psychotherapy. So I'm really, really excited about our developments with MDMA in the field of addictions.
Wonderful. Thank you very much for sharing that. It's
May I add something?
Yes, please. I was just going to ask. Go ahead.
With alcoholics and opiate addicts, if you give them MDMA post-detox, it's of great value. But if I give an addicted opiate addict or an alcoholic MDMA and he stops the alcohol or the opiates, the next day he's in full-blown narcotic withdrawal. So something is very special. For alcoholics, whatever hallucinogenic they're doing must be alcohol detox first before doing MDMA and stable. And opiate addicts also. This is, so I'm the first person who will tell you, Ibogaine is not the cure for addiction. How you get off a drug? How do I get clean without going through 90 days of hell, if there is such a thing as hell in the Judeo-Christian model? And then how do I stay clean are two different paradigms. So I think drugs like MDMA and ayahuasca and DMT and 5-MeO and ketamine are all of great value in helping people stay clean, even if they're working 12-step programs or whatever. But let's remember the difference between drugs like, cocaine and amphetamines, where the physical withdrawal is more mental, as opposed to drugs where like alcohol and opiates, especially alcohol, where acute alcohol withdrawal could be life-threatening. People can die from the withdrawal. So let's remember those patients have to be detoxed first before doing ecstasy. I've also would like your opinion, Doc, because you're talking about PTSD. I've had tremendous success using IV ketamine for PTSD. And we're not doing therapy. So we're not talking to the patients while they're under this 1 to 2 hour ketamine infusion, but it seems like they are self-diagnosing. Patients have told me that was the equivalent of getting 10 years of perfect therapy done,
Yeah, I haven't got any clinical experience of using ketamine therapy. We are about to open a ketamine clinic, we're hoping, very soon in the UK. I'm very keen to ensure that we're doing not just infusions, but we're combining the ketamine experience with psychotherapy as part of a psychotherapy course, either during the acute experience or certainly very soon afterwards, and certainly on preparation and integration days surrounding the drug sessions. I think there's a lot of ketamine infusion clinics springing up all over the place, and there's no doubt that ketamine has a pharmacological antidepressant effect that works to manage depression for a short period of time, a few weeks, with no psychotherapy. But I think that those clinicians that are just infusing ketamine and not doing any associated psychotherapy could be missing a trick there. I do think that if we know this with all the psychedelics, just taking LSD could be useful or not, just taking MDMA could be useful or not, just taking magic mushrooms. But when you take it as part of a combined course of psychotherapy with preparation sessions and building up an agenda, and then you have the integration sessions, it's a much, much more powerful effect. So I'm really looking forward to getting into using ketamine-assisted psychedelic psychotherapy in the near future.
I agree. We actually do hours and hours of pre-ketamine elicitation. And then, like with all psychedelics, I tell the patients you're actually traveling. So I give them this example. Like if I say, come fly in my plane, and I know how to fly the plane and you don't, I jump out with a parachute, things aren't going to go very well. So I tell them your vehicle of travel is the music. If you're listening to the music note by note by note by note, you can't have an intrusive thought. It's the same thing as meditation. Why does meditation beneficial to us? Because I'm blocking out intrusive thoughts. So I don't want to be having this conversation. And I tell the patients, make believe you're pick an instrument and make believe you're playing in front of an audience of 30,000 people. And if you follow the music, the thing will take care of itself. And we give them the same instructions for ibogaine, and they gently float into this without fear. If you're going to do these treatments, there are those patients that will panic, the control freaks, as soon as the drug hits them. And I have a unique protocol. How do you stop that? As opposed to somebody's coming in who's already suicidal, and now 5 minutes into ketamine, you stop it, and now they're a treatment failure, and you've made their depression worse because now even ketamine doesn't work. So I have a way of taking the edge off so those patients can actually finish their treatments. But there is some evidence coming out of Yale that after a series of some as little as 4 treatments given in a 30-day period of time, and some patients have done as many as 13 treatments, on PET scans, we're seeing it's actually fixing the brain. Certain areas of the brain that were not firing before, certain pleasure areas of the brain that were not active due to synaptic pruning are now turned back on. And we're seeing 6 months
with ketamine or in combination?
Well, ketamine and ibogaine. Ibogaine, we know, makes glial-derived growth factors, so we might be actually building new healthy brain tissue. But unlike antidepressants like Prozac and NRIs, SSRIs, which is just, helping you for a day, ketamine may be helping you for life. I believe ibogaine is helping you for life. I'm also a great believer that every great leap in the history of man, from the time Neanderthal stood up on 2 feet, happened because some Neanderthal was probably walking around and started to eat some mushrooms and grew a frontal cortex. I tell people, I believe ketamine is, if you think you're the most mentally stable person in the world, I still believe ketamine will be of some benefit to you. Ibogaine has some risk to it. So, you have to pick your patients carefully. Again, there is a protocol, but we're talking about addiction. So right now, what makes ibogaine so incredibly important and so incredibly special is that it's the only substance that exists on this planet which will stop acute opiate withdrawal in less than 24 hours. And it works like nothing else works. And I've been giving away this information for 27 years. I've met with the CEOs of major pharmaceutical companies, and they say to me, Jeff, is there a way people can take this drug every day? And this is what bothers me. So these companies now, and I won't mention names, but you know who they are, who are buying up every company, rich.com young fellows with, forward thinkers, but they're looking at drugs like 18-MC and noribogaine, which are breakdown products, which maybe will help with addiction and maybe won't, but they are not psychedelic. And if you speak to most patients who have gone through a flood dose of ibogaine, they will tell you that the value of that introspective psychedelic experience is what really changed their lives forever. So to take the drug that is not psychedelic, yet these companies that say we're investing in psychedelic medicines are now researching drugs that are not psychedelic. And this is this disconnect of trying to have to, use a back door to get these drugs approved. What is psychiatry? Let's find commonality in human behavior and then give it a name, and it becomes an illness.
Can I make a comment there? Because obviously I take a slightly different, more approach to this idea. Nobody's debating for a moment the value of the psychedelic experience in treating addictions and a whole host of other psychiatric treatments. That ain't going anywhere. That's here, it's burgeoning, it's a growing thing. And psychedelic and the intense psychedelic experience from the normal compounds of whether it's psilocybin or ibogaine or whatever is here to stay. And so it should be. That's great research. But I, as a psychopharmacologist, I also take the view, if you can carry out creative and clever psychopharmacology research to change compounds into analogs with different spectrums of effects and therefore broaden the patient tolerance to a larger population, then why not? If it turns out that psilocybin or LSD with its psychedelic effects switched off still has some physiological benefit for patients, then why not? And I think that there's a lot of the psychedelic community who, when they read of this research, they, in my opinion, were irrationally fearful. Oh my God, we're going to lose LSD. We're going to lose magic. They're not going anywhere. All we've got is LSD, magic mushrooms, plus potentially some new and interesting analogs with slightly different effects and maybe no psychedelic effect. But if they work, and it's a big if, why not? So I don't have anything to fear by broadening the spectrum of pharmacological options with this kind of research. I think it's clever, focused pharmacology. Putting aside the whole capitalist aspect of it for a second.
My fear is that by finding non-psychoactive drugs that create the same effects, that people are missing the whole aspect of having the plant. I believe these drugs are sacraments. In flood dosages, they are truly sacraments. There is no language that can describe the experience. It's outside the paradigm of the three-dimensional universe we live in. And, dancing with Shiva on 2,000 mics of LSD is very different than microdosing. Most of my patients will tell me, even if they relapse, it's that spiritual experience. I will be accountable for my behavior when I pass on, or maybe some insight into what death is about, or people going in saying, I'm a total atheist, coming out and saying, I believe, I know there's something because I just met them. The commonality of visions, tapping into universal consciousness, I think is incredibly beneficial. And us, kind of taking a step back to come up with compounds that big pharmaceutical will like because people have to keep taking them. Literally in the US model, and this is why all these studies are not being done in the US, no drug is a good drug unless you have to keep taking it. So they asked me, is there a way you can take Ibogaine every day? Can we turn it into a shot that people take once a month? Look at the Sackler family. They made, $80 billion getting the country addicted. And now they're following big tobacco's formula and doing this in other countries, even though they're bankrupt in the US. So, right now, even detox, there is no hope for an opiate addict to get detoxed in the United States. We classify drugs as class 1 to 5. Class 1 has no medical use. Class 2 are drugs that are narcotics. As a doctor in a hospital setting, I can no longer use a class 2 drug to detox a patient off class 1 and 2 drugs. That leaves me nothing but Suboxone. So Reckitt Benckiser, that owns the patent to Suboxone, is saying the best any addict can do is harm reduction, stay on this drug forever. And that's just not true. This is a lie. And somehow it bothers me that we as psychedelic researchers and chemists have to kind of bend backwards a little bit to, satisfy big pharma. And this is why Hoffman called LSD my problem child. In 1948, he realized that these drugs, these ancient drugs have been used for 3,000 years, do not fit into Western civilization's paradigm. And that makes me sad, And when you say
I think the problem that I've come up against is, there's, as I said, there's absolutely no denying the benefits of psychedelics. So this is not up for question, and I'm not arguing that at all. It's one of the biggest factors that's overshadowed all of my career is about making these drugs accessible on the public health system. And there's no question of the sacramental value and the history and non-Western indigenous uses and prehistory uses. There's no question of the spiritual aspects of that to these drugs and the benefit of that experience. The point is that when it comes to getting drugs licensed and approved, you just have to jump through certain hoops. And I'm just looking at some of the comments here, and you can't medicalize psychedelics. It's as simple as this, okay? If we don't medicalize psychedelics, they're not going to be approved as medicines, and we're not going to be able to use them on our patients. Now, we can still use them underground, we can still use them legally, we can still go to shamans, whatever, but the vast majority of my patients sitting in front of me in my clinics, they are not people who are ready to, nor need to, have to subscribe to some stereotype genre in order to go there. These are hard, shaven-headed, tattooed, tracksuit wearing, lager drinking people who have no interest in psychedelics. They would run a mile if I put sitar music on and lit some incense, and yes, nor should they. And why do we have to conform to these stereotypes of psychedelia? What we need to do is increase accessibility. We have 660,000 untreated cases of PTSD in the UK, and they cannot all fly off to Peru. You know, we need to make these drugs legal and licensed. And the only way to do that is to do the data, get the Excel spreadsheets up to speed, put all that to the MHRA and the EMA and the FDA, because that's how you make medicines. Now, we could just not do that. We could say, oh man, let's keep the doctors out of this. Yeah, fine. And we stay where we are. We've had 75 years of ridiculous drug prohibition, and we can't have another 75 years with these drugs remaining underground. So there is a lot of experience and a wealth of expertise within the underground psychedelic community in the last 50 years of practice, which we need to bring into medicine. But we can't take the other polarized position of the docs are all evil, the pharma companies are all evil. You know, it's just not going to happen if we don't play that game. You can knock on the door of 10 Downing Street and the White House as long as you want, saying, it's not fair, man, it's my right to get high. It ain't going to work until you do the data and you work with the system. That's how you get medicines legalized and licensed. And then my worthy patients who deserve these medicines can access them on the free public health system on the NHS. And that's my goal.
I do want you to realize that.
For 1 second, just before, I just want to give us, just so that you guys know, we've got about 5 minutes left. But I just wanted to say, this is where we see the evolution of what we're doing, because really it's about harnessing all of these things that we know to be true. You know, I come from sort of a cognitive libertarian background, to say the least, and you know, have a great respect for the sacrament of this. And I think we really do need social medicine right now. So this is where we have to come together and build the bridges where we can, and work with ideally like-minded and let's just say moral entrepreneurs and people who are bringing this forward to actually get this out to as many people as possible. It's neither good nor bad. This is really a great thing that we have to evolve through.
Excuse me for a minute. To say the people who still want to do LSD and do mescaline and things, something has happened now. Being a forensic expert, I've testified in many cases of people who took something that looked exactly like blotter LSD, and it was not LSD. It was something called NBOME, and they died. Right now, I don't know why. Who are these evil people that are making fake LSD? All the cocaine is cut with a substance called levanosol, so even it's not safe to do drugs like cocaine. And in Miami, when we have the music fest here, we pay people $20 to drop in the cup, and we analyze it. They really take ecstasy, and 98% of it is not MDMA. So this appearance of fake drugs is dangerous. And, you know, we're living in interesting times now, you know, where people who want to have this experience have to really make sure, you know, that they're with ethical people. You know, like I said, the tips, you know, right time, right intention, right place, right substance, you know, standardization of dosages too. If we're going to use these medicines for a treatment, we all have to make sure we're using the same medicine, same purity at the same dosage. And I do agree, it's a dawning of a new age, but it's a slippery slope. What happens when only certain people with white coats are allowed to give this drug to people? So let's remember the state of Florida had more doctors with degrees from Harvard and fancy medical schools handing out OxyContin and oxycodone to teenagers, and got the whole country addicted. So, you know, leaving this to physicians and saying that, you know, people, because they have a sheepskin on their wall, are going to be ethical worries me too. These are, you know, powerful.
One of the things that Albert said just before he died was, when the psychedelic renaissance occurs, the doctors must not be allowed to run the show.
No
and
shit.
I think that's great.
I agree.
And I don't think he is. And, you know, I've undergone the approved training for both MDMA and psilocybin, and it would be unthinkable to do that sort of thing in British medicine 10 years ago. And there we are, sitting in meditation in these psilocybin sessions and in MDMA training sessions, and talking about the inner light and the healing effect of this piece of pharmacy. That's, you know, it's extraordinary. So the doctors are not running the show. I think we're getting the balance right. I think we are doing some really good studies at the moment to harness the powerful effects of psychedelics, hold on to the magic of psychedelics, hold on to the sacramental aspect of it. Because like you say, Jeff, it's like, there's no denying that state. It's not describable. It's ineffable. The really difficult thing is, how do we harness that into something that is reproducible and accessible to all. So, for example, when we were filling in the ethics form for our MDMA study, I wanted to put something like opens the heart chakra, and we said, no, you can't give that to ethics. You can say creates a strongly felt positive mood. You know, so you have to change your language. You have to adapt, because if you try and talk to the ethics committee about opening heart chakras, you're not going to get approval for that study. So, but I think a lot of the psychedelic community are really upset and fearful that something's going to be lost. I don't fear that. I don't fear there's a magic that we're going to lose. It's a bit like going back to when homosexuality was illegal, and us saying, oh, wasn't it great when it was illegal? It's just so not fun now it's legal. You know, this is ridiculous. Legalizing psychedelics, when people say to me in conferences, Ben, do you worry about the over-medicalization of psychedelics? I say, I worry about the under-medicalization of psychedelics. We've had non-medical psychedelics for 50 years, and my vast number of patients cannot access them because they're not medical. If these are that good, then we should be able to share them. And don't fear that we're going to lose the magic. You know, no amount of people in white coats is going to take away the magic of 2,000 mics of LSD. Trust me, we know that. So there is no magic to be lost. It's not either or, it's both and. We keep the shamanistic practice, we keep the indigenous communities, we keep the raves, we keep the parties, we keep the festivals, we keep the underground use, we keep the illegal use. But we also have hospitals where people who have no interest in that part of the world can go and have their medicine prescribed in a controlled scientific setting. That, to me, is fantastic public health.
Agreed. I'm going to hop on really quick because I'm actually getting messages that we're about to wrap up. So this is really an incredible conversation, and I'm seeing so much interest in the chat. So please, there has been a group chat that was started, I believe, someone named Josh started it. If we could get maybe that link put back up on so this conversation can continue. In the last 3 seconds that we have, because we don't really have time to take questions, I'd love to know in the shortest time, what are you most excited about for addiction specifically with your work? Jeff, what's your most excited thing? What do you want to work with all the time moving forward?
Listen, I've known since 1997, I have the cure for opiate dependence. The cure for opiate dependence, not for addiction. I hope in my lifetime I see that treatment available in a safe, ethical, clinical, medical protocol at a price that could be affordable for addicts who suffer from opiate dependence.
I do too. Admirable work. Ben?
So for the future for addictions and psychedelics, you know, I want to be using these incredible, unique pharmacological compounds that have the capacity to, as I said, do the holy grail, to turn around fixed narratives that develop in childhood. I am useless, I am a failure, it's my fault, I deserve abuse, only heroin or alcohol is going to stop me feeling that way. No amount of other medicines or psychopharmacology or psychotherapy to date has really effectively tackled those core trauma aspects that become so fixed and rigid. And I've seen that with MDMA. I've seen it behaving like a classic psychedelic in the way it tackles those core rigid narratives. And that really is a fantastic and exciting opportunity for addiction psychiatry.
If anybody wishes to contact me, want some information, Jeffrey@camletmd.com. Feel free to contact me. Any knowledge I have, I am offering to give away.
Amazing.
Thank you.
Especially in light of this shared global experience we're having right now. We all know that we're going to absolutely need to face a second pandemic, they're saying, of mental health, and having these tools available to people and researchers and practitioners such as yourself is really how we're going to get there and create access. So I'm really grateful to have heard this. I know everyone is really excited. You've got best session so far. So, I mean, bonus for that one.
Yay.
I think we're wrapping up now. And I mean, we're going to be switching gears because now we're going to Bruce Linton and discussing the investing aspect of it. So, I mean, apropos of your statement earlier, it's definitely, it's really interesting to see all of these different people come together to get this to where it needs to be. And coming out of the cannabis industry, I know that you got money, you got regulation, you got science, and we're all just going to keep going up and up and try to get to a
I
shared
just
vision.
hope in the future, like every medical conference that goes on, it should be mandated and every speaker must state if he has any financial interest in anything.
Yeah, thank you for that. That was actually really, really heartening to see and to hear. And I also suggest to SciTech to perhaps maybe, look into having that part of their programming.
Thank you for having me.
All right.
Thank you very much for everyone involved. It's been fantastic.
Yes.
Thank you. I think they take